A very good evening to everyone. In this video, I'll be talking about the different forms of vitreous hemorrhage, natural cause of vitreous hemorrhage, and investigations in case of the vitreous hemorrhage. I have to just cover this topic very fast. I should have done it by yesterday. I should have completed it by yesterday, but it's fine. Different forms of vitreous hemorrhage. Hemorrhage into Burger space, retrolental space of egglet and the canal of Petit, except for the canal of Hanover, or in the space generated by a posterior vitreous detachment, retrohyaloid or subhyaloid hemorrhage, are also considered VH. Burger space, it is the space between the lens and the patellar fossa, and it is outlined by Vigous ligament or retrolental ligament, and it extends from the vitreous to the posterior lens capsule. And the canal of Petit is between the hyaloid zonules and posterior limb of the zonular fork of the lens zonules, and then canal of Hanover between the anterior and the posterior limb of the zonular fork. And the space generated by a posterior vitreous detachment, retrohyaloid or subhyaloid hemorrhage. Retrohyaloid, subhyaloid or pre-retinal hemorrhage means it is the hemorrhage that occurs between the posterior hyaloid phase, that is the detached posterior vitreous membrane, and the internal limiting membrane of the retina. Between the posterior vitreous membrane and the retina, when the hemorrhage occurs, that is called as pre-retinal hemorrhage or subhyaloid hemorrhage or retrohyaloid hemorrhage. Are also considered vitreous hemorrhage. Blood within the Burger space settles down and forms a crescent-shaped pool with the hyaloideo-capsular ligament as its inferior border. Blood within the Burger space settles down and forms a crescent-shaped pool with the hyaloideo-capsular ligament as its inferior border. When it is in the Burger space, it forms a crescent-shaped pool, and its inferior border being hyaloideo-capsular ligament. Hemorrhage into the canal of Petit also has crescent-shaped superior border. So Burger space and canal of Petit, they have the vitreous hemorrhage, which has the superior crescent border, and in Burger space the inferior border is limited by hyaloideo-capsular ligament, and in canal of Petit it has got superior crescent-shaped border, which is also formed by the hyaloideo-capsular ligament. The superior border is formed by the hyaloideo-capsular ligament. Blood in Cloquet's canal. Cloquet's canal means it's the canal that accommodates the hyaloid artery. Hyaloid artery that supplies the developing lens, and it undergoes the regression, and it disappears by the 38th weeks of the gestational age. Before the birth, it's not there. It degenerates or it is resorbed. Then, so blood in the Cloquet's canal outlines its inferior border, and blood in the retrohyaloid space generated by a vitreous detachment, retro or subhyaloid hemorrhage, can collect as a meniscus at the inferior vitreoretinal demarcation. A clinically similar appearance is caused by hemorrhage into the space between the internal limiting membrane and the nerve fiber layer. Subinternal limiting membrane hemorrhage. Now, what is that hemorrhage? That salmon patch hemorrhage that is present, that is seen in the sickle cell anemia, it is also present in the internal limiting membrane and nerve fiber layer. So if this this is the similar the subhyaloid hemorrhage can have the similar appearance to the salmon hemorrhage that is seen in the sickle cell retinopathy. So, a clinical similar appearance, that is to the subhyaloid hemorrhage, caused by the hemorrhage into the space between the internal limiting membrane and the nerve fiber layer, that is called as subinternal limiting membrane hemorrhage. In the latter, obviously the blood is under tension and doesn't shift with the changes in the position of the patient's head, as observed in subhyaloid hemorrhage. Subinternal limiting membrane hemorrhage has been described in penetrating ocular injury. It doesn't, subinternal limiting membrane hemorrhage, it doesn't only occurs in sickle cell disease or sickle cell retinopathy, it occurs in penetrating ocular injury. Then Tyson syndrome. Tyson syndrome, it is the syndrome in which there is intracranial bleeding um, associated with the intraretinal hemorrhage. Then it is called as Tyson syndrome. Anemia, Valsalva maneuver. Valsalva maneuver I have already discussed how it is done. Closing the mouth and the nose, holding the breath for 15 to 20 minutes and straining as if you are trying to poop. So it increases the intraocular pressure. It increases that pressure in the eustachian tube also. So Valsalva manu-induced retinopathy, shaken baby syndrome. Shaken baby syndrome, when you are shaking the baby vigorously and the baby's head, it moves to and forth. And then there are subdural hemorrhage, hematomas, and subarachnoid hemorrhage. It is a fatal condition, shaken baby syndrome. There can be intraretinal hemorrhage and subinternal limiting membrane hemorrhage can be seen in the shaken baby syndrome. Retinal macroaneurysm. Aneurysm is the outpouching of the capillaries. When it's macro, then it is macro, means micro and macro, obviously. Visible to the naked eye, macro not easily visible to the naked eye. Diabetic retinopathy and branch retinal vein occlusion. So these are the differential diagnoses of subinternal limiting membrane hemorrhage, that is between the internal limiting membrane and the nerve fiber layer of the retina. In contrast to the above-mentioned types of hemorrhage into defined vitreous spaces, bleeding into the vitreous gel, intravitreal hemorrhage, shows no characteristic borders and rapidly clots. So when it is present in the vitreous proper, then it doesn't have any characteristic borders and it undergoes clotting rapidly. Visual acuity with vitreous hemorrhage and retained macular function is primarily determined by the location and density of the hemorrhage. Only small amounts of blood are necessary to cause a substantial reduction in the visual acuity. Around 12.5 pl of diffuse blood in a 5 ml of phakic or 10 pl of diffuse blood in a 4 ml phakic vitreous cavity may decrease the visual acuity to hand motions. So, in phakic patients, it is just 10 pl of diffuse blood in the vitreous cavity, that is of 4 ml capacity, and in aphakic patients, It's just 12.5 ml of the diffuse blood, and vitreous capacity in aphakic patient is 5 ml. So this much amount is enough to reduce the patient's visual acuity to just hand motions. Natural course of vitreous hemorrhage. There are certain unique biochemical features of the vitreous in catabolism of blood, like rapid clot formation, slow lysis of fibrin, persistence of intact red blood cells for months, and lack of early polymorphonuclear response, obviously because there are no blood vessels. So it's all going to be lysis of the fibrin going to be slow, polymorphonuclear response is not there, it's very slow. Extracellular lysis of red blood cells, spontaneous clearance is more common in disease which have no recurrent bleeding, syneresis of vitreous gel, and in elderly and aphakic patients. The vitreous hemorrhage does not clear as spontaneous in patients with diabetic retinopathy. Long-standing vitreous hemorrhage with an ochre membrane. Ochre membrane is made up of accumulated red cells, obviously red cell debris, suspended in and mixed with the vitreous collagen. So collagen and red blood cell debris. Complications that can occur must be looked for, such as hemosiderosis bulbi, retinal detachment, glial and fibrovascular proliferation, and glaucoma, ghost cell hemolytic, hemosiderotic, hyphema, and staining of ocular structures. So what are the complications of long-standing vitreous hemorrhage? It can lead to the hemosiderosis bulbi. It can lead to the fibrovascular formation, proliferation. It can cause tractional retinal detachment. It can cause the glaucoma, ghost cell glaucoma, hemolytic hemosiderotic glaucoma. Ghost cell is also known as hemolytic or hemosiderotic glaucoma. Then there can be hyphema, seeping of the blood into the anterior chamber, staining of the ocular structures. Glaucoma, neovascular glaucoma can also cause secondary if the pathology is NVD, NVE. So host cell, what are host cells? These are the epithelial cells lacking the cell nuclei, but the cellular structure is intact. But mature red blood cells, anyways, they don't have nuclei, so these are the dead cells with no hemoglobin in them, but cellular outline structure is similar. Like similar means intact. That is host cell. Fellow eye. Evaluation of the fellow eye can often help in diagnosis of vitreous hemorrhage. Common conditions of the fellow eye that help speculate cause of vitreous hemorrhage in the affected eye include diabetic retinopathy, bilateral involvement of the, in case of the vitreous hemorrhage, Eales disease, that is recurrent, diabetic retinopathy, recurrent cause of the vitreous hemorrhage, bilateral, then hypertensive retinopathy. It can be sickle cell retinopathy, retinal white without pressure, WWOP changes, retinal tear, retinal hole, giant retinal tear, peripheral retinal breaks, retinal detachment, retinal vasculitis, including Eales disease I have mentioned already, ocular ischemic syndrome, venous occlusions, familial exudative vitreous retinopathy, and retinoschisis. Familial exudative vitreous retinopathy means the periphery of the retina is not vascularized, it is abnormal vasculature, or it is not vascularized properly like ROP, but the baby is not premature, baby is mature, and even the weight is normal. So that is familial exudative vitreous retinopathy. Retinoschisis, splitting of the retina, that is retinoschisis. Retinal detachment is different, retinoschisis is different. Retinal detachment means neurosensory retina getting detached from the RPE, that is retinal detachment. And when the retina gets splitted into two in between these layers, like in neurosensory retina, that is retinoschisis. We should also look for any retinal detachment in fellow eye. Fundus findings in Eales disease. Now, Eales disease, what is Eales disease? It is peripheral vascular phlebitis seen in 22, the age group affected is 20 to 40 years, inflammatory conditions, that is vasculitis. And it is retinal phlebitis, but it is not, it doesn't involve the posterior pole commonly. And now, what is posterior pole of the retina? Posterior pole, it is the 5 to 6 millimeter diameter circular area of the retina in between the superior and inferior inferior temporal artery that involves the optic disc and macula. 5 to 6 millimeter area bounded by the superior and inferior arcade artery, temporal artery, and it includes the retina and the macula. So that is the posterior pole, and it is not commonly involved in Eales disease. It is a peripheral area mainly involved in the Eales disease, but there can be central variant of the Eales disease also that we'll see here. So retinal phlebitis is characterized by mid-peripheral venous dilatation, perivascular exudates along the peripheral veins, and so perivascular exudates are there, but along the peripheral veins, and superficial retinal hemorrhage, vascular sheathing, ranges from thin white lines limiting the blood column on both sides to segmental heavy exudative sheathing, peripheral vascular sheathing, and hemorrhages along the or exudates along the vessels, peripheral veins, retinal veins. Then fine solid white lines retaining configuration of normal retinal vasculature as a remnant of obliterated large vessel. Sharply demarcated junction between the anterior peripheral non-perfusion and the posterior perfused retina. Vascular abnormalities at the junction between the perfused and non-perfused zones such as microaneurysms, veno-venous shunt, venous beading, and occasionally hard exudates and cotton wool spots can be seen. So we can see the vascular abnormalities like microaneurysm, dilatation, outpouching of the capillary walls. It is because of the loss of the pericytes or pericyte dysfunction. So we know venous shunts. Shunts, these are the vessels when there is ischemia, then in order to supply the ischemic area, there is development of new vessels from the normal vessel. Okay, between the two vessels, these connections are established. That is called as shunts. So we know venous shunts are there. Venous beading is there. Bead-like appearance, like segmented. Venous beading, occasionally hard exudates. Hard exudates means leakage of the lipoproteins in the outer plexiform layer. That is because of the break in the blood-retina barrier. Blood-retina barrier, tight endothelial junctions, and the pericytes forming the blood-retina barrier. And cotton wool spots. Cotton wool spots. So cotton wool spots. These are white, fluffy, pale white or pale yellow, fluffy. Uh, Lesions on the retina, and these are because of the axonal nerve fiber. These are present in the nerve fiber layer, and it is because of the axonal nerves failing because of the ischemia. So these hard exudates, they resolve. It takes months to resolve the hard exudates because of the leakage of the lipoproteins, and they may leave behind the scar or RP pigmentation, underlying RP pigmentation. And cotton wool spots, usually they regress in 6 to 18 weeks. Yeah, and the difference between them is the layer and the histological composition, and their disappearance and their appearance. These are pale yellow, white, fluffy white, and indistinct border cotton wool spots, and these are bright yellow, yellow white with relatively more distinct border hard exudates I'm talking about. So neovascularization, NVE, NVD. NVE, neovascularization elsewhere. NVD means not just the vessels on the disc, but NVD means the vessels which are present within the one disc diameter area from the margin of the disc. So that area is also taken as NVD when the neovascularization is present in that one disc diameter area from the margin of the disc. That area, the new vessels in that area is also considered as NVD. Recurrent vitreous hemorrhage, proliferative changes, tractional retinal detachment. The macula is usually not involved, but when it does, it is termed as the central Ills disease. In this variant, all mid-peripheral lesions appear in the posterior pole. I told you, posterior pole between the superior and inferior uh, arcades, temporal artery arcades in the retina, and it is a 5-6 millimeter diameter circular area, including the macula and the disc. So central variant involves a posterior pole rather than the mid-peripheral region. Um so as the macula is going to be involved, it causes the loss of vision in the early stage of the disease. And C-fan new vessels may be there. C-fan new vessels, as it is the characteristic of one of the characteristics of sickle cell retinopathy. sickle cell retinopathy, salmon patch, and C. fan new vessels. So differential diagnosis of the vitreous hemorrhage with causing the media opacity. So in between the media opacity that can mimic the vitreous hemorrhage, obviously it's very easy to identify the vitreous hemorrhage on fundus examination, but still the differential diagnosis: vitreitis, amyloidosis, lymphoma, hyalosis, vitreous degeneration, leukemic vitreous infiltration. Now this hyalosis, what is hyalosis? Hyalosis, it is usually unilateral. It is seen in patients more than 60 to 70 years of age, and it is made up of the calcium crystals, and it looks like that starry sky appearance. And when the patient moves his or her eyes, the crystals, they move, and then they don't settle at the bottom, they return back to their position from where they were vibrating or moving with the eye. And what is the difference between asteroid halosis and synchytic scintillans? Synchytic scintillans, these are made up of cholesterol crystals, and they settle down at the bottom once the eye movement is done. They move with the eye movement, but then once the eye movement stops, they settle at the bottom under the effect of the gravity. These are made up of the cholesterol crystals. Relatively younger beings are involved, especially in diabetes, hyperlipidemia, diabetes. In this patient, synchytic scintillans is seen, and synchytic scintillans is rarer than asteroid hyalosis, and bilateral involvement is there in synchytic scintillans. So that's the difference between asteroid hyalosis and synchytic scintillans. So media opacity is because of the vitreous cells, or vitreous opacity can be seen in vitritis, uveitis, posterior uveitis, amyloidosis. Then I'm not going to go in detail about the amyloidosis because it's a big thing. Like, it will include the pathology in every system. So in short, I'll just put the pictures here. Lymphoma. Again, lymphoma, I'm not going to go in detail. Asteroid hyalosis, okay, it is like localized disease here in case of the eye. Vitreous degeneration. Vitreous degeneration means abnormal cross-linking of the collagen in the vitreous. Then leukemic vitreous infiltration. So that was about the different forms of the vitreous hemorrhage, natural course of vitreous hemorrhage, and fundus findings in the Eales disease, and importance of the fellow eye examination, especially in the bilateral diseases: diabetic retinopathy, hypertensive retinopathy, Eales disease. Then ARMD, myopic changes, myopia, especially pathological myopia. Then familial exudative vitreoretinopathy, ocular ischemic syndrome, venous vasculitis, or inflammatory diseases. Investigations based on the disorder suspected. Systemic investigations, obviously the cause of it. For example, if it is hypertension, then any cardiovascular event, ECG, then chest X-ray. Diabetes, for diabetes, blood sugar fasting, postprandial fasting, it should be between 70 to 100, and if it is more than 126 milligram per deciliter, then suspend the diabetes mellitus fasting, and postprandial should be less than 140 milligram per deciliter, and if it is between 140 to 190 or 200, then it is pre-diabetes mellitus, and if it is more than 200, it is diabetes mellitus. That is the blood sugar level. Blood sugar level is importance of the blood sugar level. Then complete hemogram, anemia can cause vitreous hemorrhage. Then coagulation profile, important BT, CT. Then prothrombin time, activated partial thromboplast time, INR, if the patient is on morphine, and heparin. Then erythrocyte sedimentation rate, C-reactive protein, vasculitic, giant cell arthritis, all the vasculitic diseases, inflammatory diseases, peripheral blood smear for anemia, enzyme linked immunosorbent assay for HIV, Venereal Disease Research Laboratory for syphilis, Mantoux carotid Doppler scan for cardiovascular events, ECG, chest X-ray, echocardiography. Fundus fluorescent angiography, indocyanine green angiography. Once media is partially or totally clear, angiography can be done for deciding on management or diagnosis. Obviously, if there is a severe vitreous hemorrhage or even moderate vitreous hemorrhage, if it is done in acute cases, FFR, ICG, there will be blocked fluorescence, so we won't get detailed idea about the retinal vasculature. So once the hemorrhage is settled down, then when there is substantial clearance of the vitreous hemorrhage, one can go for fundus fluorescent angiography or endocyanine green angiography. Ultrasonography, sonosoundgraphy, picturization, ultra means over. So ultrasonography, the sound waves more than 20 kilohertz are used here. So there is a scan and B scan. A is amplitude scan, B is brightness scan. So more than 20,000 hertz. More the frequency, better the resolution, less is the penetration of it. So in this case, we go for the B scan, brightness scan. On B scan, the vitreous cells and vitreous hemorrhage, they look similar, so you have to correlate clinically these two things to differentiate in between two things. So ultrasonography extremely important in the management of media haze. Actually, there is one video on Inside Ophthalmology about the uh, ultrasonographic findings in vitreous hemorrhage, B scan in case of the vitreous hemorrhage, and how to differentiate between the vitreous hemorrhage, vitritis, and other conditions from the vitreous hemorrhage. It is nicely given over there, and even the basics of the B scan and A scan. There are separate videos. You can go through these videos on Inside Ophthalmology channel. Ultrasonography is extremely important in the management of media haze related cases. Multiple scans must be taken, including transverse and longitudinal, just like in screening ultrasonography, transverse and longitudinal. If the whole or a part of underlying retina is obscured due to vitreous hemorrhage, ultrasound B scans with corresponding A scan is mandatory to detect any associated retinal detachment or mass lesion. During the scan, emphasis should be on three sites: the vitreous cavity, vitreoretinal interface, and retinochoroidal layer, obviously. With ultrasound, it is possible to differentiate between fresh and clotted hemorrhage. Unclotted hemorrhage with no cellular clumps may not be visible ultrasonically. So if it is unclotted hemorrhage, fresh hemorrhage, and no cellular clumps may not be visible ultrasonically. Asteroid hyalosis is one condition that may appear similar to clotted vitreous hemorrhage on B scan. It allows determination of the location and density of the vitreous hemorrhage, the location and extent of traction membranes and retinal detachment, and the vitreoretinal relationship, all of which may help to predict the visual outcome after vitreous surgery. Status of the posterior vitreous detachment and its differentiation from retinal detachment is necessary. Rarely, retinal breaks may also be picked up. Some patients may need repeated retinal evaluation and serial ultrasonography in 7 to 10 days to reaffirm the cause and again rule out any retinal detachment or retinal break that would warrant an early surgery. Typically, patients with acute posterior vitreous detachment need repeat ultrasonography. For example, if the patient comes to you and if there is severe vitreous hemorrhage, you cannot see the fundus, go for B scan, and then you will see the acute PVD. And when there is acute PVD, if you see, then you go for repeated scans just to see if there is any retinal detachment, because the vitreous hemorrhage and PVD in 70% of the cases, 70 to 75% of the cases, there is underlying retinal tear, even the retinal detachment. And that's why it's very important to repeat the ultrasonography in case of the acute PVD with vitreous hemorrhage. X-ray, CT, MRI, and even the scleral indentation is important if there is vitreous hemorrhage and acute PVD. To see if there are any retinal breaks. X-ray, CT, MRI, occasionally computed tomography, and magnetic resonance imaging are performed on patients with VH, for example in Tietze syndrome. Yeah, MRI and CT brain wide is important if we are suspecting Tietze syndrome. Like CNS symptoms and intraretinal hemorrhage, go for CT MRI to look for any Tietze syndrome, because Tietze syndrome means intracranial bleeding along with the retinal hemorrhage. To evaluate for intracranial hemorrhage, computed tomography does not easily differentiate hemorrhage from the surrounding vitreous. Why there should be what is the connection between the intracranial hemorrhage and the uh, retinal hemorrhage? Because they have the subarachnoid space, common subarachnoid space. It is postulated, but it is controversial whether it goes down through that way and enters the retina. Or another posture, another group that postulates that it is because of the raised intracranial pressure that affects the retina. Intracranial pressure, increasing the intracranial pressure, what it does, it will compress the veins, and then compression of the veins, that pressure, it goes back to the retinal veins, and retinal veins, they become engorged, and then the stasis develops and retinal vein occlusion occurs and the hemorrhage can occur. So these are the various postulations about why the intracranial bleeding is associated with the intraretinal bleeding in Tietze syndrome. So for that, CT and MRI, computed tomography does not easily differentiate hemorrhage from the surrounding vitreous, may also be useful in cases of the trauma. So hemorrhage, during hemorrhages and all, you can just go for the CT, it will pick up in the brain, but it won't pick up, CT won't pick up the vitreous hemorrhage easily in the vitreous from the surrounding tissue. From visually evoked response, it may be useful in cases where visual prognosis is doubtful. So if you are planning for retinal detachment surgery, obviously visual evoked response, it will help to take the patient, whether the patient should be in the nil visual prognosis or guarded visual prognosis, that surgery should be taken, and the patient should have the idea about the prognostic value of the surgery that patient is undergoing. So for that, visually evoked response test can be useful. So that was about the investigations in case of the vitreous hemorrhage. In the next part, I'll be talking about the management of the vitreous hemorrhage. I'm done.